Okay, I have 8:30, so we'll go ahead and get started. I see folks are still trickling in. Good morning and welcome, everyone. My name is Raghavi Anand, and I'm the Quality and Learning Manager at the Maryland Primary Care Program Management Office. Thank you so much to everyone who is in attendance today. We appreciate your dedication to the program, yourself, specifically expanding your knowledge and skill set, as well as Marylanders to improve the quality of care they receive. We'll start with a quick welcome message from the MDPCP Executive Director. I'll hand it to you, Chad.
Morning. Thanks, Raghavi. Hi, I'm Chad Perma. I'm the Executive Director of the NDPCP Management Office here at the Maryland Department of Health. Excited to be here today with all of you and really appreciate you taking time out of your busy schedules to learn with us. First, a brief word on advanced primary care in Maryland. As you guys know, MDPCP is really a key component of the overall healthcare transformation here in the Maryland healthcare delivery system. It allows primary care practices to play an increased role in prevention, management of chronic disease, and preventing unnecessary hospital utilization. You're at the center of this critical work. You should also know that MDPCP is the largest Medicare advanced primary care program in the nation, both by number of practices and on a per capita basis. You should also know that you are at the center of this work and this movement. You and your colleagues here have accelerated that here in Maryland. But the program is only as strong as the staff in our primary care practices. Primary care practice staff, such as yourself, are at the center of changing the delivery system. In fact, the practices in the program serve as a model for the nation, and we couldn't do any of this without you. So what should you expect at today's event? For some background, we've had several previous staff training academies. The last staff training academy was held virtually last June. This event covered many topics that you'll see again this year, and also some new ones. Our Learning and Quality Manager, Raghavi Anand, will talk more about what sets apart this staff training academy from last year's and others that we've held in the past. At this staff training academy, we have some great speakers from around the nation who are lined up to discuss relevant and timely topics with you, from billing and coding to cultural responsiveness and more. So again, thank you for attending today. We look forward to hearing from you about this event, including your takeaways and opportunities for improvement. You'll have the opportunity to share this feedback in the post-test survey. Most importantly, we hope you'll leave here with a deeper understanding of skills and ideas about how to improve primary care for your patients. I'll hand it to Raghavi to say a few words and discuss housekeeping.
A great message. Thank you so much, Chad. I'll quickly introduce the team assisting with the Staff Training Academy today. You'll see us with these blue backgrounds. We have myself, Shiva, Kelsey, Timmy, Kemi, Bemi, and Chika. And these are the teams from MDPCP as well as JIA Staffing. Big thank you to JIA Staffing for helping us to make today possible. I will quickly note that if you have any questions or need assistance throughout the course of the Staff Training Academy, you can identify us with these blue backgrounds, or you can for troubleshooting or tech assistance, join the breakout room titled Tech Support. We'll have that reminder at the bottom of every slide, but just wanting to call that out. No need to request to join. You should be able to join that breakout room directly. We'll jump into a few housekeeping items here. I do have the distinct honor of being present here today to kick off this innovative, timely, and relevant Advanced Primary Care Staff Training Academy. Whether you've attended a staff training academy in the past or if this is your first one, we're excited that you're here. What sets this year's Staff Training Academy apart, as Chad previously alluded to from previous ones, are the clinical and non-clinical tracks. We want to tailor this content to your training and background to ensure that it helps improve your ability to provide the best patient care. One more key distinction is that we are diving deeper into the topics we covered last year for a more in-depth look. So you'll see that it's not just an overview or a beginner level of review of content. We'll go much deeper into content. To make sure everyone has the same background information, the Staff Academy is designed for primary care practice staff for the purpose of expanding knowledge, developing tools, and improving areas of expertise with respect to advanced primary care functions. We hope that based on this information, you'll set some personal goals for yourself for today's event, whether that is expanding your knowledge at one session, learning something new at one of the sessions you'll be attending, or deciding to engage with the presenter during the Q&A session. Before we move on to the good stuff, I'll just take a minute here to cover some housekeeping items that you see on the house rules page here. As a best practice, we ask that you keep your phone and/or microphone muted if you're not talking, and especially during presentations. We want to make sure everyone can hear our speakers clearly and that we minimize any feedback or background noise. We anticipate that many of you will have questions either for the speaker during their session or about the event. We encourage you to submit your question using the chat feature on the Zoom control panel. For questions about the event, we'll address that in the chat directly. Any questions you may have for the speaker will either be addressed during the presentation or at the end of their presentation. You can raise your hand when you have a question for the speaker. To claim 4.5 free continuing medical education credits from AAFP, please make sure to take the pre-test, attend the training, and complete the post-test. For technical difficulty, again, you're welcome to contact Zoom support, but if it's something that we can help troubleshoot live, you can join that breakout room titled MDPCP Technical Support. With that, I will turn it over to Chad to introduce our keynote speaker.
Thanks, Raghavi. Now I have the distinct privilege to introduce your keynote speaker. She's a friend of the program and one of the brightest minds in improving primary care delivery. Dr. Rebecca Etz is a professor of family medicine and population health at Virginia Commonwealth University. She's also the co-director of the Larry A. Green Center, Advancing Primary Healthcare for the Public Good. Dr. Etz has deep experience in qualitative research methods and design, quality and accountability, primary care measures, practice transformation, and engaging stakeholders. Her career has been dedicated to learning the heart and soul of primary care through two main lines of inquiry. One is bridging the chasm between the business of medicine and the lived experience of the human condition with research that demonstrates the integration of medicine with the fullness and dignity of humanity. And two is exposing the ways in which current trends in healthcare transformation and stakeholder engagement fall short of their desired goal to bring the worlds of medicine, public health, and communities together in collaboration for improved population health. Without further ado, Dr. Etz, the floor is yours.
Thank you. I really appreciate it. It's a pleasure to be here with you guys today. I am truly a fan of the MD PCP program, so it's a real honor to join this morning. I want to talk about looking for primary care, and I'm going to start out with talking about the 3 simple rules of generalist care. Now, this is something that my colleague and co-director of the Green Center, Kurt Stengy, and I wrote a few years ago in Family Medicine. Primary care is so incredibly complex and broad. It's part of why I love it. But you really can do it well if you follow 3 simple rules to guide you in your work. The first of which is to recognize the broad range of opportunities in front of you. And when we say that, what we mean is the minute somebody comes in seeking your help, they are presenting you with conversation. They are presenting you with not just a set of symptoms or a problem, but they are presenting you with a moment in their lives. And you have the chance to determine what sorts of things you can do with this. Is this a healing moment? Is this a teachable moment? Is this a bonding moment to help with a concern that goes on in something in the other than their physical life? So the first thing we do is we stay present. We focus on the person in front of us and we recognize what is being presented. And then the second thing we do is prioritize our attention. We prioritize our attention and our action based on the idea that we want to provide that moment of healing or hope or connection. So of all the things that they share with us, what are the things that require most attention today? And understanding that means paying attention to what they feel is most important about the interaction, as well as what we find to be most important about the interaction. The third rule then is to personalize the care in context. And this is probably one of the most challenging. We have to take all that we know in terms of good evidence. We have to take all that we know in terms of their medical history and apply it to all that we know about their context, about the situation in which they live, the point in their lifespan in which they sit, the social networks in which they are embedded. And these rules sound like they're progressional, but they're interchangeable. We're constantly redoing them. So as we get more new information about what's going on, we have to again recognize the person and what the opportunities are for today. So this is something that you're probably familiar with. You do that in practice. This is also something that we think, whoops, I went one too far, sorry. This is also something that we think applies to this 3 simple rules of quality improvement. For quality improvement, you want to think about where you look, what you see, and how you perceive the moment. And where you look is really important. It's the evidence that we know is significant. And when you were all kids in school and you were learning how to, I don't know, understand the Great Depression, we were told we could go talk to our grandparents and interview them about their experience, and we could present that in school, and that was good. And somewhere along the line, when we get to high school and we're told to write a paper about the Great Depression, we know that is no longer the evidence that's significant. Here we have to look at books or articles. There's some other kind of work. Evidence that matters is always in front of us, but it's whether or not we know how to see it. So the seeing, that second simple rule of quality improvement activity, is about how you perceive the thing in front of you. What's the orientation you take to it? Is it your perception that you adopt, or is it somebody else's, say the patient's in front of you? And then the third thing is to know how to perceive the moment. Perceiving the moment is about understanding that everybody will face challenges, everybody will face optimal goals they want to find. How do you look in the future? How do you use the knowledge you have and think ahead of right now? Think of what's coming so that we can prepare people so they have their most optimal lives as they encounter that next thing down the road. So the first thing we're going to look at, or that I want to talk about, is where you look. And that's why I have this slide here of Zora Neale Hurston. I'm a big fan of hers as well. She was a fabulous writer and activist, a real leader during the Harlem Renaissance. And by the time she passed away, nobody knew who she was. She died of poverty in an unmarked grave. It's a really tragic story. And it wasn't until Alice Walker, really then a grad student and unknown, uncovered the story of Zora Neale Hurston that we got to have her come back to our knowledge base. She's now an institution in the worlds of literature and journalism and history. She feeds most of the stuff that we know today, and she died in poverty. So Alice Walker, as she discovered this, decided she needed to find her grave and put a marker on it. And we only knew that her grave was located in an acre, and it was really an acre that was unkempt, overgrown thicket. She was out there with a stick going through the grass, trying to make sure there was no snakes, as she was looking for this woman's grave, some kind of indentation in the earth. And she found it, and she made sure that the area was clear so that others would have a path to follow. She marked Zora's grave so that others would have inspiration on which to draw. And in case I'm being too subtle, I am actually suggesting that that's what I want you to do today. I want you to think of yourselves as people who are forging forth in a field that still needs inspiration and still needs notice. And it needs you to make the path and mark it so that others can follow it clearly. The second thing is how you see. Once you get there, how do you see the things around you? And this really is about perception. And here I draw on Ed Young, because I love this book he wrote, An Immense World. Each chapter, you should read it, each chapter focuses on a different animal of the kingdom and how they perceive the world around them. What does it mean to be a bird, for instance, who actually can see 360 degrees at any given time? We see only what's in front. What would our perceptions be like if we could see all around us all the time? If we're in a room and the light goes out, we perceive a change. If you're a bat, you don't. They perceive sound, not light. So what does it mean to not only see things, but to perceive them with the significance of someone other than yourself? In the world of primary care, it is our patient's perception that is paramount. What is of most value to them? What is most significant to them and how they receive? That's how we ensure that we get to pay attention to the fullness of their dignity as we help them while they're seeking care. The third rule then is about how to guide your perception so that you can see that moment and be able to prepare people so they can act on it. Here we want some inner guidance. Here I look for principles to follow, the first of which is having a solid North Star. As I've mentioned, that really is a patient's perceptions and values for me. The second is actually the health system, or the health of the system. And this matters. We tend to think of it as non-human, we tend to think of it as an obstacle to our day, but it's the system that helps us to take care of the broad sense of the population. And it is important, and it is incumbent upon us to know what the entirety of our community or population is doing. How is their health as a whole? And how are we doing on the whole to be attentive to the needs and stewardship of their health? So there is accountability here that's good, but we need to be responsible in our accountability. We need to follow things that are meaningful to others as well as ourselves. And we can do that if we have that personal motivation that comes from our professionalism, not doing something because it's a rule we follow or the new protocol we learned, but doing something because we feel internally driven to follow the best professional standards that we understand and apply them in a way of shared expectation with those for whom we are providing help. That's really the goal here. So, are we going to be accountable? And accountable would be following a piecemeal-like rule to create something that looks recognizably like a practice in which I might get care, but not necessarily the one I would want to go to. And this works for some people. This image is actually a very famous building in Brazil. But I want something that is also responsible, that feels organic to the environment, in which it feels part of the environment in which it's created. I want this practice that recognizes me and celebrates all parts of me as well as itself, so that we exist together towards a common good. I had the privilege in 2011 of doing a project for the Robert Wood Johnson Foundation, in which they asked me to identify 200 exemplary practices around the country. And I'm going to share just a couple of stories from them with you today, because they really were exceptional. These were people who were doing continuous quality improvement before it was a thing. The first was a practice that had a tax clinic. This was extraordinary. This was a practice that was on the edge of a community that was really Section 8 housing. The average income was $10,000, and people were struggling to make ends meet. And they realized, and it was in April, they realized that the people who went to their practice were not turning in tax returns because they weren't earning enough to actually have to pay taxes, but they didn't know about earned income credits. So the practice got some high schoolers to come in after school and turn in 1040 easy forms for their patients. And they called it their tax clinic. And in the first year that they did this, they brought in $7 million to this community in tax refunds. I want you to think about that for a second. This is a practice. It just had some high school students come in and volunteer some time, and they brought in $7 million to a community in which the average income was less than $10,000 a year. That is addressing the social drivers of health. The second example was from a practice that was in an industrialized area. And during the Great Recession, they created something called the More Than Money program. And this also really is one of my favorites. They said, if you haven't graduated from high school and you want to earn your GED, if you were a new parent and you wanted to take new parenting classes, or if you simply wanted to donate hours to a local community organization, you could do that. You could call a human, a real live person at the practice, and report the number of hours that you did and what the activity was. And they would credit your bill $10 an hour. Now, this was important. It was an FQHC. It had a sliding scale. $10 was a copay on a visit. And they were finding in this community, in which unemployment was at 20%, that people had stopped coming in to take care of themselves. And when they instituted this program, they said everybody came in. And I said, well, of course they did. You were paying for the care as well as providing it. That's quite the deal. Of course they came in. And they said, no, you're not getting it. That when you take care of the community, they take care of you. And what I still remember it because it was so extraordinary. What they said was that at this practice, in which the debt load, that is the amount or the percent of unpaid bills they had, their debt load was the lowest it had been in 30 years during the Great Recession. And that's because the community took care of them. They paid their bills there. They knew that these were the people that had their backs. People who had commercial insurance chose to go to the FQHC because they were taking care of their community. It was a wonderful story. So having these two examples in mind, we created the person-centered primary care measure. We wanted to connect measurement, accountability, and responsibility with something that was meaningful to care. We were inspired by these practices, and we set out and we interviewed and surveyed thousands of patients and clinicians, and we came up with this measure. It's one of the things that we're known for, the person-centered primary care measure. And it's 11 simple items, and it reflects professional norms, personal motivation, and the needs of those seeking care. It's what people find most important. This is one of the reasons I'm asked to talk to people each day, but you can do this too. So, we went backwards. Don't know why, sorry. So you can do this too. And it's not like I have a crystal ball. Although if I did, I'd get the slides going right. Apologies for that. But it's not like I have a crystal ball, but there are certain things coming up that I want you to keep in mind. What's on the horizon for healthcare? The first is patient perspective. I've talked a lot about it today. We know that this is important. Patient perspective is enjoying a newfound importance. This has become increasingly important to CMS. It's become increasingly part of how we are held accountable to providing good care. It's more than patient experience. It's more than simply knowing you did a thing. It's understanding the significance of that thing to the people that we are trying to take care of. So be purposeful and be present and in the moment. Understand the evidence in front of you from the perspective of the person in front of you. The second thing that we need to think about as we look at the future of primary care right now is the tension between standardizing care, following best examples, and personalizing that care. That's the real craft, as my friend Will Miller says, when we bring all our evidence-based, our best knowledge, and we apply it to the context and our knowledge of the person in front of us. How do we maintain that personal connection even as we develop standards that guide our care? The third thing is the use of artificial intelligence. This is just, man, it's taken off. Some people are nervous about it. They sort of think of those sci-fi movies and it's going to take over the world, and some people are just excited about it. I would encourage you to think of AI as something simple, similar to a calculator. It is a powerful tool. It is one that helps us. It can do many things for us, but it does not take over significance. It can process data, it can organize data, it can group it for us, it can make it more easily accessible. It can put in front of us what we have trained it to know is most important to us in a moment, but it cannot tell us why that is significant to us in that moment or the person in front of us. As we adopt more AI, we can do so paying close attention to the relational connection between people, understanding that facts are not meaningful unless we have a relationship that provides significance and meaning to that fact. The fourth thing is about big data. This is also really attractive and can really be dangerous. Big data can help us to understand amazing things, but it also has a romance about it that causes us to forget the systemic inequities that are often baked into how the big data was put together. If there's bias in how it's collected, there's going to be bias in what we can learn from it. So we must always be attentive to that. We had many areas in the country that did not pay significant attention to this during the pandemic. And so we set up mass vaccination sites, hoping to get as many shots and as many arms as fast as we could. And we weren't paying attention to the fact that places in which it's easy to set up mass vaccination sites also tend to be places that have a lot of resources. And it left some of our most vulnerable people behind, the people that we in primary care would have prioritized. The fifth thing is really that continuous quality improvement must have a continuous counterculture focus. And I'm being a little nerdy here, and I hope you forgive me. But Gail Stevens was a guy that informed primary care. He talked about the field of family medicine, and he said it was counterculture. And since it was during the late 60s, many people combine it with the moment of the 60s, but it wasn't quite that. What was so counterculture about what we do, he said, is that we hold the social in the same significance as the scientific, the same significance. The ways in which health are won and lost is based as much on the science of a person and their biology as it is the social of a person and their biography. And we have to hold both of those together in unison to understand how health is won and lost over time. So that's what I want to suggest to you, that as you go through your day and you're learning all your new skills or beefing up skills that you already have, that you remember these simple rules of knowing where to look, how to look, and how to perceive the moment in ways that are attentive to what is, I think, in the future, our biggest challenge, which is remaining continuing to have a focus on the attentiveness of the relational meaning of being human, even as we explode in our ability to have mechanized and automated decision aids. So that's what I have today. I can turn it back over to the group, and I hope I've left time for questions. More than happy to receive them, and thanks for having me.
Thank you so much, Dr. Etz. I'm sure we have some questions coming through shortly. For those who do have questions, you're welcome to raise your hand. You're also welcome to drop it in the chat.
We can also shift it off the share if there are faces on the screen for me to see.
Is this better?
Yep.
Thank you, Heads, for your impactful presentation. I will now read out some of the questions we have. So
Sure.
the first question, referring to your example with Sarah Neil Hudson, can you illustrate an example of a care provider paving the way for others with a new approach or new angle to help their patients?
Sure. I get a lot of inspiration from the people that I talk to during the day. One of the people I recently was able to speak with was Douglas Eby. And if you don't know him, he is a chief officer at South Central Foundation. It's a wonderful FQHC in Alaska. And in the early 1990s, South Central had the dubious honor of being one of the worst practices in the country. And they actually blamed it on the US healthcare system. And they moved from US healthcare to the Indian Health Service. And they focused on what they call consumer owners. And it's a wonderful model. They became one of the best practices in the country. And I don't mean best primary care practices. I mean, literally, they got the Baldrige Award as the best medical practice in the country. And exceptional. Here's something that they do. They have an interest in people not getting cancer from smoking or using tobacco products, just like we do. But rather than seek out people who are using tobacco products and talk to them about quitting and focus on what's the number of people we have using and how can we get them to quit and what have we done to get them to quit, they instead hold aspirational goals. They say, we want our population to be 95% tobacco free. We're at 92% tobacco free right now, and we're really proud of that. And we continue to work on that goal. So the way that they present it is not one that's based on seeking out the bad people and punishing them. It is based on recognizing the resilience of the community as a whole and celebrating that so that people want to be part of it. It just changes the orientation a little bit, and it makes the encounter and discussion one that is about aspiration rather than one that's about pointing out faults.
Hey, thank you very much. The second question I have here, you mentioned AI. How do you think it may change healthcare as we know, and how can providers prepare for these changes?
This is a really hard one. I think AI has already started to affect healthcare, right? Like a lot of people use ambient AI to take notes, where we used to do them ourselves, believe it or not. Some people actually used to handwrite them on paper. Sometimes now we type them into an EHR, but now we can have an automated AI do that for us. Sometimes we use them to create automated notes for instructions when you're going home after a basic procedure. We can use them to say, here are the records, and this is already being done. Here are the records of 15.5 million people who have had diabetes, and you can know everything about them. And now when somebody comes in front of you, you could put into this AI what you're seeing, how they're presenting, and it can spit out for you, of all the information we have, here's how we know you can best help the person in front of you based on that information. These things are amazing. They are really amazing and powerful. It used to be when you were a clinician and somebody came in and you needed to do a differential diagnosis. And when I say used to be, I mean like maybe 30 years ago. It used to be you had to have 20 or 30 things in your mind to think of to know to take care of this person. Now you have to have literally over 1,000. It's really hard for the human brain to do that on the spot. So having AI, having some sort of system that helps you to crunch through all that information is extraordinarily helpful, and that is being developed. At the same time, I was heartened to see last year that we are starting to get some executive orders coming out of the White House to help guide how that AI is used. It can only learn what we teach it. So sure, you've got 15.5 million records of patients with diabetes. Are they all rich, white, affluent people living in the Northeast? Because if that's the case, then what you share with them of a presentation of somebody living in Louisiana or somebody living in New Mexico, it's not going to be as accurate or helpful. And in fact, it might be harmful. So we see AI providing lots of power, and we are training it, and it is learning at an amazing rate. I think it will be able to help us in many ways, much the same way that Atul Gawande's checklist started to help surgeons to keep down errors in surgery, right? These are amazing first steps. I suggest, though, that we need to be cautious in the thrill of our adoption and pay attention to where potential weaknesses may lie. So that executive order I referred to now requires that every time AI is shared, also it must share data cards. That is, where the data come from that fed it so it could learn, so that we can know if what we're being presented with is evidence that matches the population that we're taking care of.
Okay, thank you so much. The next question, what are actionable steps that providers and primary care staff can take to ensure that continuous quality improvement has a continuous counterculture focus?
I love this. Okay, so paying attention to the person in front of us, really paying attention. You know, I work on a lot of, CMS asked me if I would work on a new measure for them on the mental, behavioral, and social health of individual beneficiaries. And sure, yeah, we can do that. But no measure helps. No tool helps if the person who's using it is not attentive to the person in front of them. People know if you're paying attention to them. They know if it's honest. If you are on a keyboard, yep, how can I help you today? How's it going? Oh, good, I'm so glad. And you're talking like that, they're gonna know you're not present with them. At the same time, this is not an algorithm kind of thing. You can't tell people, make eye contact, make sure you nod your head when listening to show active listening. Yeah, how can I help you? Also, doesn't matter. It's intentionality. It's what you actually are thinking inside and expressing out. Make sure you are with the person in front of you in the moment. It makes a world of difference. And we can often feel like, I don't want to ask questions for which I cannot provide help. That can be extraordinarily burdensome for people who deal with vulnerable populations, for instance. You see lots of need. You see lots of help or opportunities for help. We often forget that the simple act of bearing witness is healing. That if somebody can talk to you about the challenges of their day, you need not do anything but listen, and listen intently, and let them be recognized and seen. Respect their dignity. and it makes all the difference. This is, I think, the biggest challenge to continuing quality improvement. The other challenge is to think that continuing quality improvement is just a rote activity, that we have a new goal that somebody's put in front of us, we measure things at baseline, we do some silly activity, we measure again, and it's gone up and everybody's happy. And if we just follow that process and we don't think about what we're doing, our challenge is that the only thing that gets better is that one little thing that we paid attention to in that moment, and it does so at the expense of all the things around it. Continuity is a really hard one, because if you pay attention to access, it's hard to also pay attention to continuity. Make it easier for people to get in fast, it's harder to get them in to see the same person. And sometimes we get distracted by that, and we think right time, right care, third next available, that these are all things that should be guiding us. And we should understand that if somebody is experiencing a high fever and having chills and feeling really miserable, it probably does matter to them that they get in today. But if what they're looking for is an annual physical, getting in today may not be the most important for them. So getting connected to somebody who really understands them may actually be the more important thing. During the pandemic, we actually surveyed, because people also think, oh, everybody wants convenience today. Look, they go to the minute clinic, or they go to their urgent care or the ER, and they want what's most important, most convenient, cheapest. And what I like to say to them is, oh my God, you're mistaking what people are purchasing for what they prefer. They're purchasing what they can get. They're maximizing what they can get in the moment. That doesn't mean it's what they prefer. It means it's what's available to them. And when you survey them and you ask them, do you want to go to a minute clinic, or do you want to go to a traditional practice where the people know you? They want to go where they're known. They're just not always able. I also point this out, and I hope I'm not offending anybody. And so here I really have to say, I'm speaking just for me, not anybody else. I haven't studied this. This is just me. It's not anybody else. But oh my God, if ever there was an example, Haven started and stopped. And Haven was some of the biggest minds, biggest business minds in our country. Warren Buffett and Jeff Bezos, who leads Amazon, and JP Morgan, right? That Walmart expanded into primary care. Who doesn't know how to be convenient and low cost more than Walmart? Who doesn't know how to market and brand things? And they had to pull out of primary care because healthcare is not a consumer activity. We have some really big examples of this now, big, gigantic failures. Healthcare is not a consumer-based activity. It's not convenience. People want connection. That's the biggest challenge for continuous care. And if you always have that element in it, if you always pay attention to the relational knowing of the human in front of you, you'll have the most success.
Thank you for that. So the next question, what are some of the key trends and changes in the landscape of primary care quality improvement and accountability that providers should be aware of, and how can they implement this?
It's also a great question. You guys this is good. Probably one of the key changes is the focus on patient perception. There's a great interest in understanding if we are meeting the needs of our population. We often now talk about person-based care as opposed to patient-based care or patient-centered care. And that has to do with understanding that people should not be seen as a sack of problems. People are simply people. And they sometimes have concerns, and they sometimes have wishes, and we need to be attentive to all of them. And have open and free conversations of all aspects of our lives that may affect our health journey. And it's really the focus. We can be distracted and think that the role of future care is about coordination, case management, in the way that we make sure all the pieces are moving and all the feedback loops happen, and conversation gets started and completed. And those things are important, no doubt. But real care coordination in the way that we first introduced it in primary care was not that. It was a corrective to a system that is fragmented when you seek care, and you have to go to someone there and someone there and someone over there. And it is very difficult for somebody who does not have medical expertise to pull all that together and to understand how that makes a coherent story for me. And the person who was over there gave me advice that conflicts with what the person over there said I had to do. And how do I make sense of that? And we require a human now more than ever. We require a human that can help us make sense of our personal health narrative and what we need to do. And all the wearables that we have are great. They give us extra information, but they also give us a little extra anxiety. We don't know that it's normal for heart rates to fluctuate during the day. But now we have watches that show us how they happen. And we look at it and we call up our practice in a panic because we see something odd. During the pandemic, people with allergies had fears about sniffles and coughs like you wouldn't believe because they couldn't understand what was going on and they needed a person to give them some comfort. That is the future of what we need to pay attention to. So I see that as a big challenge. The other thing that I see is how clinicians handle the massive influx of information. There was a wonderful study done by a guy whose name is Ted Ganietz, and he used to be the director of the Agency for Healthcare Research and Quality. And it was great. He talked about how you put a bunch of specialists into a room and a bunch of primary care docs in a room, separate room, and you present them each with new things that they have to do. New guideline, we have this new guideline, you present it to the specialist, and they look at all the work they do and they say, okay, I can adopt this new guideline, and the way I'll do it is I'll stop doing this thing so I can do this new thing. And in primary care, what we do is we say, okay, add it on. And we just add on, and we add on, and we add on. We can't do that. We have to start to prioritize things. And I know that this may be somewhat heretical. So again, I remind you, this is my opinion. I'm not representing anybody else. But maybe it's not so bad that people get a flu shot somewhere other than their primary care doc. Often giving a flu shot is a cost leader for a practice. It maybe is not so bad that you have places like Costco or CVS that are able to provide that. The problem we have with it isn't that they do it. It's that we lack good health information exchange so that people can know that their patients have gotten the necessary thing, and when they haven't, that they should follow up. That's a challenge for us, but understanding that primary care maybe cannot do all the services that it used to do is also going to be one of the challenges, because we have almost an internal mechanism that prevents us from feeling like we can let go of anything we used to do to take on some of the new things that we absolutely must do.
Okay, thank you. And the next question, would you speak more to your statement on healthcare and consumerism, especially as MDPCP comes towards the end of CHP's survey period? Thank you.
Sure, I missed the first part of that. Can you repeat it again?
Okay, could you speak more to your statement on healthcare and consumerism?
Healthcare and consumerism, sure. This is a huge danger that we face with the increase of venture capitalists and corporatization in healthcare. Healthcare is not a business. It is not a consumer-based industry. And that means that the same things that guide it and the same thing that guide people's interest to use it are not the same things that guide how you pick out the book you want to read or the favorite shirt that you're buying. We have different impulses for that. Our danger is to think that, like consumers, that what we purchase is what we prefer, that the marketplace will allow the best to compete, that we have free choice of the goods that we buy or the goods that we choose to buy, that everybody has an equal opportunity to purchase the same things. And these rules that govern our consumer-based world are not the same as the ones that govern healthcare. Not everybody has the same access. I was on the national consensus study for the National Academy of Sciences, Engineering, and Medicine. And one of the things that we produced in our report in 2021 on how to implement high quality primary care was we explained that primary care is a common good. It is like air or water. We need to make sure that our entire population has access to clean water and clean air and primary care. It's one of those things. And we cannot compete our way to having better primary care. It is not a cost that we should be thinking about for the system. It is an investment in the health of the population. And that takes a slightly different orientation. And that means that as we think about how we organize our care, we shouldn't be thinking about individual pieces and how individual pieces get us a better rate on investment or a return on investment. We should be thinking about long-term in the lives of people, how do we best invest in their optimal health? And when we do that, we actually get better outcomes. We get all those things that the business world wants us to get, but we don't get there by using the business model. A great example of this was when Chris Kohler was the director of insurance for the state of Rhode Island. He insisted that if you wanted to use and sell health insurance in the state of Rhode Island, that you had to invest more money in primary care. Right now, we invest about 6%. It's a little under 6% of our national healthcare spend in primary care. He said in Rhode Island, you need to increase your spend in primary care by 1% each year. And they did that for 5 years. Over that course of time, not only did they increase the resourcing that primary care got on the whole, and this wasn't from corporations, this was part of the taxpayers, not only did they increase the money that primary care got, but they found that overall for the state, they decreased the use of health services. They decreased how much they spent on health services. They actually got the triple aim. It happened almost instantly. They got better health, better experience, smarter spending. It didn't take a lot. It took understanding that it's not consumer-based. It is societal-based. It is a social norm and value. And we should treat it as such. And when we do, we get the rewards we seek.
All right, thank you, Dr. Head. So the last question for this session, can you comment on the role of interprofessional care, how critical it is? How do we get providers to collaborate without fear of losing scope of practice?
Yeah, interprofessional care can be amazing. There are some places that do this like just absolutely exceptional. Interprofessional care is when you have people with different expert knowledge bases contributing to the care of the patient. And this need not be a threat to anyone's scope of practice. It actually allows people to expand their scope of practice. We have some great examples of practices that developed during the pandemic, for instance, the ability to do telehealth-based consultations and working in closer relationship with specialists through consultations. The primary care provider actually learned how to better do some, like in the case of dermatology, how to better take care of some conditions in their own office. It sort of upskilled them, having a closer connection. And then the dermatologist in return felt more valued because the stuff that they got to take care of was the stuff that was more in line with their rate of knowledge. So it ends up actually feeding both people. People in each case got to work to the top of their license, even though that's a term I've come to not really love so much. It fed them both in that way. So it can be really good for the patient. It's an extraordinary thing because if you can go somewhere that has an interprofessional team, your experience of care is less fractured. You can be in one spot and somebody can step out and somebody else can step in, or they can step out, get some quick advice and step in. And for you, the care is seamless. So it can be really, really powerful. It is hard on a training level, especially at the medical school level, because often the schools have competing curriculums and timelines. And so it can be hard to get people to sync up. So to make this work well, you need to do that training, I think, in the work environment as part of a QI activity. And you can't expect that it will be smooth in the beginning because each discipline has their own way of seeing. and their own way of perceiving what's significant, and they don't necessarily naturally talk to each other in the same language. That's the challenge with the QI around that. But those teams can be extraordinarily effective and actually expand scope of practice on both sides.
Thank you so much, Dr. Etz. I think those are all the questions that we have. However, I will note that if folks have additional questions, they're more than welcome to drop those in the chat, and we can send those over to Dr. Etz to answer. We'll post those answers on the website.
And I will pop into the chat my email address. Anybody is free to reach out and ask me a question or seek some advice anytime. It'll be my pleasure.
Thank you so much.